Hello there, going live. My name is Julie Hirschberg. I am a neurophysical therapist. I am the owner, founder of Re+active Therapy and Wellness here in the Los Angeles area. And I love to hop on here and share a little bit about what we're reading and learning and doing as a team here at Re+active. And this week is no different. And in fact, I've been doing a lot of reading. I've been prepping along with my amazing colleague, Brittany Charlet. She's our concussion program director. We are prepping for a free workshop that we're doing for people who are post-concussion. It's next week, next Thursday at the lunch hour, and we are going to be talking about some of the evidence, what's going on in the brain with persistent post-concussion symptoms. We're going to talk about treatment evidence, and we're going to talk about our treatment approach, particularly about an integrated team approach. So, of course, as usual, when I start reading things, I get really excited, and then I want to share it with you all. So today, I'm going to pop this up right here, and of course, my dogs are going to start barking. As soon as I hop on here, I'm going to take care of them. As soon as a squirrel walks by, my dogs go crazy. It doesn't happen all day until I hop on a live. So excuse my dogs. So I want to talk about this article. I actually found and this article from a tweet from a colleague. So if you're a therapist like me, you should be on Twitter and follow your favorite colleagues and researchers. They share all their most recent papers. You get it like right away. So this was called post-concussive orthostatic tachycardia is distinct from postural orthostatic tachycardic syndrome POTS in children and adolescents. Now, we talk a lot about POTS around here too. We see a lot of people, we treat a lot of people with POTS. And so even just the title here really grabbed my attention, because sometimes when we're testing and screening things, it's like, well, this isn't really like POTS. But there is some autonomic dysfunction. There's some tachycardia. Maybe it doesn't quite fit. Maybe not all the symptoms are there. And this particular study, very well done. I am so fortunate. Brittany is so fortunate. We have had the really awesome opportunity to collaborate with this group at UCLA. This is the Brainsport Group. And one of the great things about this study is that they looked at all of the encounters of people post-concussion who came in to this program. So it's a large study relative to many other studies that look at this. So that's really positive. So I want to talk about some of the highlights, and I'm going to start by bringing up, I grabbed some pictures here because I think it's really important to know who we're talking about in this study. And so I always really go through like, well, how did they get this data? Who was included? Who was excluded? So you can see that they looked at people retrospectively over the course of, 3 or 4 years, and they had 450 patients. So a large number of people. They excluded some of those. So some of them weren't post-concussion. Some of them weren't kids and adolescents. Some of them had a severe TBI. Some of them had a pre-existing diagnosis of POTS. So that would exclude from this analysis. So anyway, I wanted to show you that they kind of whittled down to different groups that were included in the analysis. The final cohort was 268 patients. That's a good amount of people to be analyzing, which I think is really helpful and lends to some of the interpretation of the data as we go through. Now, let me pull back for just a moment because I did get some questions, and I do, here, I'll stop sharing this for a second. I want to just go back from kind of a bigger picture thing. So reactive for sure, and in the world of post-concussion for sure, we see autonomic dysfunction. Sometimes it's not tested out well. This is often what we're screening for when we do a free consult for a person for our programs. We're asking questions about autonomic dysfunction. When we see people in person, we're testing out autonomic dysfunction. It is a known issue for people after concussion, and particularly when people's symptoms persist for a longer period of time. Now, the mechanisms for this are not fully understood. And that was a big impetus for these researchers to really do the study. POTS has been described post-concussion. Changes in heart rate variability have been described post-concussion. Pupillary dynamics, so pupillary control, another autonomic sign. And these are all part of our post-concussion pie chart, right, in that autonomic section. These are known to happen. It's not fully understood why these happen post-concussion. And orthostatic tachycardia. So that is elevated heart rate when a person goes into standing, and in prolonged standing is something that is seen post-concussion. Now, in younger kids, so remember this study was in adolescents and kids, they define orthostatic tachycardia as if there is a sustained heart rate increase greater than 40. In adults, it's greater than 30. Now, this is an important point because they actually analyze the data looking at both cutoffs with that question of I wonder if we're missing some people when we use the cutoff of greater than 40. So that's something specifically to think about. This is typically tested with an active stand test. That's typically what we do here at Re+active, which is taking vitals and heart rate supine for a period of time, and then in standing and for prolonged standing. It's not a quick test. It's at least 10 minutes long. So in this study, they actually modified this over a shorter period of time. I think this is really helpful because I think that could be clinically helpful for people when you're well, I don't have all of that time. Maybe a modified or abridged version of that could be helpful. And actually, some of the literature shows that could still pick up and screen for orthostatic tachycardia. So the other test is a head up tilt table test. So if you work with folks with POTS and autonomic dysfunction, you definitely know these tests. But if you don't, I often will recommend doing one of these tests as a screening measure, particularly post-concussion. And if you are a person post-concussion, you absolutely should have these screened. What I love about the UCLA program is they did this in everybody. So they had enormous amounts of data so that they could sort people into groups of those with orthostatic tachycardia and those with not. Now, the majority of people in the study did not have orthostatic tachycardia. Overall, using the greater than 40 beats per minute cutoff, it was only 7% of the total population. I'll pull up a table here in a moment. Now, here was kind of the purpose of them looking at this in this study. By the way, I'll just bring up the study again. This is what we're talking about. There is a lot of overlap between symptoms of POTS and post-concussion symptoms. They're not the same, but some of those subjective symptoms are the same. Fatigue, headache, dizziness, drowsiness, brain fog, anxiety, all of those. If you work with folks with concussion, if you've had a concussion, probably all sound familiar. And that can absolutely be related to POTS. And a prior study, this was really interesting actually. Who was this study by? I'll look that up. I wrote some notes here, but this has been found a couple of times, is that concussion in one study was the second most common trigger preceding POTS in a large group of pediatric patients, 708 patients. Concussion was the second most common cause of POTS. Infection was the first most common trigger. Another study, this was a study by Lee and colleagues, LI, they also found a similar finding where concussion could be the trigger for POTS. So this is a huge topic, huge importance. We're looking at autonomic function post concussion, and really understanding, well, is it POTS? Is it something different? And they had some really interesting findings. So I promised you a table here. So I'm going to, hopefully this table shows up. It might be kind of tiny, but I'll walk you through it. I think looking at the results of the study, not just the conclusion and discussion, but the actual results is really important. So I want you to look at the columns here. You can see overall the study population, 268, and then you can see 249 of those did not have orthostatic tachycardia. Only 19 did. So you have to really think about that's not very many people. 19 people did. But if you're a therapist like me that works in a neurology specialty practice, you're seeing those 19 usually because of the implications of some of their autonomic function on their life. It can greatly impair mobility and life activities. So one of their, I want to point you out to, so if you scroll down the table, now go to the p-values, right? So we've got 1, 2, 3 that are starred, meaning there's a significant difference between the group. The first one, which would make sense, would be their resting heart rate. The second one and the third one that make a lot of sense is the change in heart rate. So you can see that the orthostatic tachycardia group, their change in heart rate was an average of 43. 40 is the cutoff, so that makes a lot of sense. Those were the main distinguishing factors between these demographic variables for the groups. So one of the big things, and I want to point this out at the top, is the female or male. So traditionally, POTS has been a much higher prevalence in females than males. And in this group, and again, small group of people who had orthostatic tachycardia, it was not a predominantly female group. So that was one of the biggest distinguishing factors between this group of orthostatic tachycardia and traditionally what is found in people with POTS. Now, it doesn't mean that men don't get POTS. It's just that it's more common in female and adolescents than in this group post-concussion. So that was one important distinction, and kind of where, if I go back, that's so weird. Oh my gosh. Thank you, Liz. How long have I had the sound off here? Because I just noticed that maybe it was muted. Maybe that was when I moved, maybe when I changed something, I accidentally hit mute. So hopefully that hasn't been going on for so long. And now you can hear me. Thank you so much for speaking up. I was talking to myself. So let me go back a moment here to the first thing that I'll summarize is that, okay, great, less than a minute, phew. the first thing that I'll summarize is that where they say orthostatic tachycardia distinct from POTS in this group in that it was not predominantly female. The second is that the symptom profile was different. Those with orthostatic tachycardia, and I'm going to go to this data here, did not have more prevalence of a POTS symptom profile than those without orthostatic tachycardia. So there was no difference between the group in dizziness and fatigue or nervousness and anxiety. There was a difference in drowsiness. So that was one difference, but not the others. So this group with orthostatic tachycardia post-concussion might be different than those with POTS. Now, something to really think about, and this is what the authors talk about with this, is that POTS by definition is also a chronic disease. Orthostatic tachycardia post-concussion has been found in some people. Now, for sure, I see people chronically post-concussion with this, and they might have POTS, but in the more acute stages, this is a very reversible condition, and they hypothesize that potentially in those more acute stages. Now, most of these folks were not really acute post-concussion. They were definitely out more than a month from their concussion. Was, if they had a concussion, they had less physical activity, or they were instructed to have less physical activity, they could actually develop orthostatic tachycardia from that deconditioning or that rest period. And most people, as they resumed activity, no longer had the orthostatic tachycardia. So again, I'm not talking about POTS. I am talking about orthostatic tachycardia post-concussion. And in many cases, it's not chronic. It's actually reversible as a person resumes activity. I think this is really important because back in the day, and many of the people that I see and work with, they were told to not do activity, to rest. And that might actually be part of the reason they might develop some of this autonomic dysfunction. And again, this is post-concussion. I'm not talking about other disorders with this. So one of the results is that they actually had hypothesized that those with post-concussion orthostatic tachycardia would have a symptom profile that would be very similar to POTS and would be different from those without orthostatic tachycardia, and it was not. So I think this is another key piece that they found in this study. Now, I want to just bring up one more picture here, and that is here. So this is a slide that Dr. Giza, who is one of the leaders of this group, actually put out in the Twitter as he was sharing some of these findings, and some of the great researchers right here on the slide from UCLA who are looking at this specifically, cardiorespiratory autonomic dysfunction after concussion. But what I loved about this slide, at least on my left-hand side here, are the summaries, is the summary from this article where they found, and this is what I wanted to point out, this fine point, is they found 19 out of 268 of these folks had orthostatic tachycardia, so greater than 40 beats per minute, withstanding it. But if they looked at that, if they looked at some of their past history, one of their other significant findings was that those with orthostatic tachycardia did have a history or I should say, we're more likely to have a history of a prior concussion. Now, I know, and many on our concussion team know, we see a lot of people with multiple concussions. And this group particularly is looking at, well, what is happening in the cardiorespiratory system? What's happening in the autonomic nervous system? And is it possible? Now, this study didn't say for certain having multiple concussions causes orthostatic tachycardia, not at all, but it was more associated in that group. And then the last thing, this is actually not on there, but when they changed the cutoff to 30 instead of 40, I believe it was 55 people instead of 19 met the criteria for orthostatic tachycardia. And so there was some discussion, particularly in kids, because that's the adult criteria. Do we want to look at that as a potential marker instead of using the 40 cutoff? And would that allow us to screen and treat people sooner? So they didn't say, like everybody should do that, greater than 30 in kids. That is been in the literature for a long time. But just something to think about. Maybe there's somebody who's kind of on the borderline, if that makes sense. So a lot of detail in that study. I wanted to address, there were a couple of questions that came through, and one of them, and I'm not certain that it totally relates to this, but when we think about autonomic dysfunction, somebody asked, it might be 107 outside, which, bless you for living in a very hot climate. I'm very heat sensitive and I would not be able to do that. But living in a hot climate, yet being inside and shivering. And if that's ever happened to you, I know that might happen to me if I don't feel well, for example, and it doesn't make any sense at all. But also that is definitely a sign that there could be something going on autonomically with your temperature regulation. Now, there can be lots of reasons for that. For folks with a spinal cord injury, for example, might not have good temperature regulation because of the nervous system signals from their body. But that can also happen with other causes of autonomic dysfunction. Now, temperature regulation is not the same as orthostatic tachycardia, but if you start to see those pieces fit together, this is how we screen them in our program. For example, we use the composite autonomic profile, the Compass 31, to screen for clusters of autonomic symptoms. So like temperature regulation, looking at the orthostatic tachycardia, for example, we want to look at all of those and start to put together an autonomic picture because we need to treat it, right? And this is what I've been really advocating for all of us as therapists, to be screening and treating this. Absolutely. Somebody else asked, could something like 3PD cause POTS? That is not something I completely know for sure. That's I haven't looked at the literature on that, although I do stay fairly up to date with the POTS and 3PD literature. That's not something that I've seen. And POTS is really heterogeneous. There's not a, first this and then this occurs. We have learned that a concussion could trigger POTS. And the same things that could trigger 3PD, could potentially trigger POTS too, right? It's an autonomic dysfunction, and we know that the vestibular system is very intimately connected with the autonomic nervous system. So dysregulation in one can lead to dysregulation in two. In another system. Another thing I think about, which is similar in this study, where they discuss some of those ideas of less activity leading to orthostatic tachycardia. And that is definitely something that we can see, deconditioning, less activity in general, in every neurologic disorder. Now, not everybody with 3PD just stops being active, actually. I have many folks that keep moving and keep doing, and that's not the case. But I'm just putting that out there as potential hypothesis, right? That we'd want to test out. Now, I do want to say, so 3PD, by the way, persistent perceptual postural dizziness, has some similar symptoms to POTS. So the dizziness, the brain fog, even like a headache with that. You can experience all of those with 3PD, and you can experience fatigue. You can experience those with POTS. And so I think it really takes a good clinician to test that out. Does the person really have POTS, or is this their 3PD? Or is it really 3PD, or is it POTS? Or is it both, right? And how much of each of those are contributing to symptoms and your function, right? I think that is exactly what we do as therapists. And that's why I think that's why I'm getting the word out. That's why I'm sharing this stuff, because I think it's really important for therapists to know, to be able to screen. When I see a person with dizziness, I'm screening their autonomic nervous system. When we see people post-concussion, we're screening, and then not just screening and then treating it. We see this a lot in functional neurologic disorders. We can see it post-stroke. We can see it in MS. It's an important part of our nervous system that we need to screen and treat. So I went on my autonomic soapbox today. Thanks so much for joining me as we're learning and growing in all of these areas together. And I'll remind you, the reason I was popping into some of this literature, Brittany Charlet and I are doing a free workshop for people who have persistent post-concussion symptoms. It's next Thursday. It's at noon. You can join us live. You can catch the recording for that. You can go to reactivept.com/workshops to sign up for that, or you can sign up. There's a link in our bio too. So we'll be talking a lot about this stuff. We are talking about this stuff. I'm so excited. We're talking about this tomorrow in Brain Bytes. So if you're a healthcare provider, we talk about the autonomic nervous system a lot in Brain Bytes, and we're talking autonomic and vestibular tomorrow. I am so excited. And our waitlist is open. We're opening our doors soon for Brain Bytes. So join that waitlist if this is the stuff that gets you pretty excited and curious and you want to keep discussing it. So thanks so much for joining me today. And I'll send out this article, the video, and all of that to our newsletter. Get on our newsletter at reactiveeducation.com or reactivept.com. I'll see you there. Thanks.